All right, well, thank you everyone for joining us for the ultrasound lecture series this week. So last week we started talking about DVT ultrasound, and today we're going to kind of build off of that and kind of talk about a particular case presentation that can happen in DVT ultrasound, something that you may run across, in the ED or up in the unit. And so, without further delay, we are going to dive right on into that. So let's cut on over to our lecture. So, as always, I like to start off with a case, and that gives us kind of a feel for what's going on and can put this into clinical context as we kind of think through what is going on with our patient. And so in this context, this is actually not my case. This is a case that I pulled out of the New England Journal that they had written up. Let me see if I can do this here real quick. Switch back over. So it's this case right here. And if you actually look at that link at the bottom of the lecture, you can go find the write-up for yourself. But basically, it's a 24-year-old female who presents to the emergency department with a painful left leg, right? This is not something that's terribly unusual or terribly uncommon for what we would see and kind of what we've been talking about in this context. And so I guess like everything, vitals are important, so we probably should get some vital signs. So her vitals were basically a pretty normal blood pressure for a 24-year-old female. And they also mentioned in this case that she was a pretty athletic female. She'd run a bunch of 5Ks, and so this isn't kind of your person who doesn't get up and move a lot. This is a pretty active person, right? So a blood pressure of 110 over 70 is probably not going to be an unreasonable pressure for this patient. The only thing that they noted that was abnormal was she's slightly tachycardic with a heart rate of 102, but her respiratory status was fine, right? It's 18 respirs and 98% on room air. Right, and so that's kind of her vital signs. And on exam, right, kind of that third piece, you have the history of vitals and there your exam. She had some erythema to her leg and some pitting edema kind of all the way up her leg, right, on the left side, right? But otherwise, her exam was pretty unremarkable, right? So this kind of conjures up kind of a couple thoughts for us. We have a young, healthy, athletic girl who presents with unilateral lower extremity pain and swelling. And if we just connect the dots and say, hey, this is vascular month, and she's got a very typical presentation, she's bound to have a DVT. And if you are thinking that way, you are 100% right. So this is an example of a scan. This is actually one of my patients, but this is an example of what you'd see, right? And so here we have, in the still images, we have a long axis and a short axis view of the artery and the vein. So the upper one, you have the artery on top and the vein below. And then the lower one, you have the artery and then the vein, just below it. And inside that vein, you see this echogenic material, right? And we talked last week that there are multiple characteristics of DVT that we need to identify, right? So one would be the fact that it's in the vein, right? So an anechoic, thin-walled, compressible structure, right? So if we were to compress this and there wasn't a thrombus there, you'd see it completely collapse. But the presence of something that violates at least two of these principles suggests that this is a DVT. So we have an echogenic substance inside the vessel that makes it non-compressible. And if we look on the right-hand side of the video clip, we can see actually obstruction to color flow. So you see the arterial flow on the top, and then you have the venous flow on the bottom with the thrombus in it, and you can see just kind of that filling defect with a little bit of flow around it. So this patient has a left lower extremity DVT. So with that said, we can anticoagulate her, we're done with the lecture, and we can have a nice day, right? Yeah, I don't think so. So she was diagnosed with a left lower extremity DVT and treated with anticoagulation. And the question really comes for us, assuming this patient's sitting right in front of us, is what do we do with this patient, right? Do we admit them or we discharge them? And there's a growing consensus, or a growing thought, I should say, I don't know if it's a consensus yet, that you just load them with a DOAC and send them home, right? And then give them their script for a DOAC. And as this becomes more and more accessible, a little bit more and more affordable, it certainly becomes a little bit more of a plausible option, right? Certainly not unreasonable, though there are still some who would say, you know what, there's some utility to bringing them in and observing them for a night or two, getting them started on their anticoagulation and then sending them home. So we'll leave that debate for some other time. But basically, the patient is typically anticoagulated at this point, and you make that decision to admit or discharge. And this is generally where we stop when it comes to the emergency management of patients, right? This is, most of the time it probably is sufficient to take this step, and then other, physicians can follow up and continue the hypercoagulable workup. In fact, you probably are going to get a skewed hypercoag workup if you're doing it in the acute phase. So it certainly makes some sense to do that later. But that's typically what we do for these patients, right? Now, for this particular patient, right, in this article, they mentioned that the patient was started on heparin in the ED and admitted, right? So we're just going to go with that as kind of what happened. The patient was taken to the IR suite, and an IVC filter was placed, and there's a lot of conversation that can happen around that, but that's what happened in this case, right? And then they had catheter-directed TPA administered, or basically a catheter-directed thrombolysis, right? And, I was looking up in preparation for this one. Okay, so I don't generally thrombolyse all my young, healthy DVTs. Should I be? Or is this just a uniqueness of this case? And I think, it brought up that there's really not a lot of definitive, this is the one way to do it. Management for DVTs. In fact, if you look at UpToDate for just a plain old DVT, a thrombolysis isn't necessarily recommended as a frontline treatment. And then if you look up in UpToDate for this particular condition, which we'll get to in a minute, thrombolysis is a recommended treatment. So there's probably some debate whether or not that should happen. But the logic behind it, at least in the context of this patient, is if we can get that clot out of there, right, we can preserve the venous valve function and then really prevent venous insufficiency down the road, or what's called the post-thrombotic syndrome. And so it'd be kind of a bummer if you're a 24-year-old healthy runner, to all of a sudden now have one leg that just won't drain, and now you have this, large leg on the left and normal leg on the right, and I think that's going to, probably get in the way of at least comfortable running, if not, athletic activity in general. So, I can see the logic behind why they're going to want to thrombolyse this particular thrombus, but that's what happened to the patient, right? So all's well that ends well. The patient got thrombolysed, and the case presentation ends, and then we can stop now. Except for the fact that's not what happened in this case, right? There was but 5 days later she returned. So this patient, what started out as kind of a bread and butter presentation to the ED suddenly is becoming a little bit more interesting, right? She comes back to the emergency department 5 days later with a worsening of her left leg pain and swelling, right? And so she was scanned again. She was found to have another thrombus, right? And actually this one extended further proximally than the first one, which really got them kind of curious. She got herself admitted in a huge workup, and the only really risk factor that they found was that she was on an OCP, and then had a family history of a DVT in the past, but did a whole big hypercoag workup and didn't seem to really provide a lot of information, and there wasn't certainly any like recent orthopedic surgery or a recent trip or anything like that that really put her at risk for this. So that was kind of interesting. She was on her anticoagulation. She actually had a little bit of an episode of heparin-induced thrombolysis, which resolved as they kind of transitioned her to a different anticoagulant. So great, we have a recurrent DVT 5 days later. We're on thinners, right? But then again, she follows up in vascular clinic 3 months later, and she's found to have yet a third DVT. And at this point, it's getting really super duper annoying that we have a young, otherwise healthy person without a lot of ton of risk factors now with 3 DVTs in 3 months, right? This is going to be a problem for this patient. And it really illustrates and brings to light kind of what's going on with this patient. And she was ultimately, over the course of her workup, diagnosed with something called May-Thurner Syndrome. And that's going to be what we're talking about today, right? So have you guys heard about May-Thurner Syndrome? Yes or no? Kind of think through it. So this is basically a syndrome that happens to people, right? We'll get to some risk factors here in a minute, but is basically caused by a venous outflow obstruction due to extrinsic compression of the veins in the iliocaval territory. And this is, it seems like a very sterile definition, and that's because I took it pretty much directly from UpToDate, and I cited it there, so it's not plagiarism. But basically what happens, right, is we have the aorta coming down in the belly, right? The IVC going back up. both of them, and remember we talked about this last week, right? We talked about how the IVC, or the venous side, follows the aortic side for the most part, right? So when it splits, when the artery splits, the vein splits, right? And so we have this, right? The aorta comes down on the left, IVC goes up on the right. Both of them bifurcate at approximately the same place. Both of them send a branch into each side of the pelvis, and then through the inguinal ligament, or through the inguinal canal, and into the or I should say, I rephrase that, under the inguinal ligament into the legs, right? And they both become the common femoral vein, kind of, and common femoral artery as we exit, into the leg. But what you got to remember is the aorta comes from the left, the IVC comes from the right, and one has to cross over the other in order to send branches to each side, right? So what we have here is basically the right common iliac artery crosses over the left common iliac vein, right? And that crossing point can actually cause a compression. There can be a pinching between that artery and the lumbar vertebrae behind it that really kind of sandwiches that vein in there and cause some obstruction to flow, right? It can cause some stenosis kind of in that area. And this is actually one of a number of compression syndromes. If you go on Google and look up different, venous compression syndromes, there's a number of them. And I remember in medical school, they taught us about one called the Nutcracker syndrome that happens a little further up with the SMA and the left renal vein. But in this context, right, we have a compression of the left common iliac vein by the right common iliac artery, right? And so what happens, right, is not only do you get the compression, you get the stenosis from that, but you also get this intimal hyperplasia that can cause some venous stasis kind of around that area and be a nidus for that thrombus. And so then you just need another hit from the Virchow's triad, and basically, boom, you got yourself a DVT, and that can be a problem. So the question is, man, who gets these things, and how often does this occur, right? And so, if you look at it, May-Thurner syndrome is seen in approximately 2 to 3% of people diagnosed with DVT, right? So it seems kind of like a rather rare thing, but people estimate that that's probably an under-recognition of this condition, right? So it's probably a higher rate of people with DVTs. In fact, some studies would say that in cadaver models, May-Thurner syndrome, or this venous compression, can be seen in up to 25% of people that have been studied, or cadavers that have been studied. And so the incidence of this, I think, is probably a lot greater than we think, and a lot greater than we actually realize. And probably because, a lot of people with May-Thurner syndrome pretty much just have asymptomatic compression that doesn't necessarily generate a thrombus. And so, if we look, we can probably see this, or we'll probably find this. So who gets this stuff, right? There are several risk factors, and if you look at the bottom of this list, it's kind of the same standard risk factors for other people with vascular thrombi, right? If you're dehydrated, you have kind of a hyperviscous blood. If you have a hypercoagulable state, obviously you're going to get a thrombi. Radiation exposure kind of predisposes you to thrombi. But what's unique about May-Thurner syndrome is it tends to happen in women, right? It tends to be a 3-to-1 female to male predominance. Doesn't mean men can't get it, but it tends to happen for some reason in women, and in women who are in their pregnant or postpartum state, right? And we know this to be kind of a hypercoagulable state, but the typical person, right, the typical individual who is diagnosed with May-Thurner syndrome is a pregnant or postpartum female, and then again in their second to fourth decade of life. So it really tends to happen to those younger-ish, 20, 30, 40-ish year old women, right? Now, scoliosis can also be considered a risk factor, and part of that is just the abnormal curvature of the spine kind of puts abnormal, or reconfigures the anatomy in an abnormal way, and can increase the risk of that compression with the common iliac artery. So when you think about May-Thurner syndrome, or when you see your patients, right, and you see someone who's a young female, right, who has left-sided DVTs, consider May-Thurner syndrome. Doesn't mean all women who get DVTs have this, right, but it's something at least to throw in the back of your head and to think about it, particularly if they're coming in with a second or third DVT. But more on that later. So how do you work this thing up, right? We have this condition, right? All of a sudden we've discovered a new thing that we didn't really know about that's now terrifying us, because how many times have we missed this in the emergency department? So how do we work this up, right? So there's a couple different methods, right? And this is an ultrasound forum, so obviously ultrasound has got to be in there somewhere. But the reality is a duplex ultrasound, while really, really good for diagnosing the presence of a thrombus in the common femoral vein or distal to that, probably is not going to be your go-to test here because it's going to be poorly sensitive to actually diagnose the stenosis higher up, right? We talk about the fact that ultrasound or duplex ultrasound does a great job in the leg, but because of the overlying structures in the pelvis, right, because of the overlying bowel gas and things like that, it doesn't perform quite as well as we'd like in the pelvis itself. Now, it doesn't mean you can't use it, right? There's definitely parameters that if you check and see some turbulence through the pelvic vessels, that certainly can suggest it. You can do a pre and post test, or not pre and post, but pre and post lesion duplex like Doppler analysis and look and see if it exceeds a certain threshold of difference. But for just run-of-the-mill duplex ultrasound, this is going to get you the diagnosis of the DVT, but not necessarily make the diagnosis of May-Thurner syndrome. So we got to rely on some other things, right? So the next thing that probably the easiest to get for us in the ED and probably even for those in the unit is basically just contrasted cross-sectional imaging, whether that be CT or MRI cross-sectional imaging. And so this is really helpful to make the diagnosis of May-Thurner syndrome and also to assess for not only the degree of stenosis, but the location and the cause of that stenosis, whether that be from this artery or May-Thurner syndrome or some other compressive structure inside the pelvis, right? And the sensitivity is actually really good. Reports say it's kind of on the neighborhood of about 95% sensitive to evaluate for May-Thurner syndrome, right? And so this has certain advantages. And so in this example, I pulled this from Radiopedia. Here's an example. You can see that right common iliac artery compressing the takeoff of the left common iliac vein, right where that arrow is. And here's another example. You can show this is actually a certain delay contrast sequence where you can see that the venous system is lit up with contrast, and you can see that artery kind of compressing in on that vein, right? So CT or MRI cross-sectional imaging, really, really great next step if you suspect this. That being said, we got to round out the discussion with two other modalities that are of interest, and more just to kind of round it out, not necessarily because this is going to be the go-to thing that we're going to choose in the emergency department. But basically, contrast venography can also be used, right? And the downside to this one is that it's invasive, right? You actually have to wire a catheter in, you have to inject that contrast, but you get a pretty good view of that stenosis, that's happening inside that left renal vein, or left iliac vein. So here's an example of two pictures of contrast venography where you can see basically a pinching of that area in the stenosis of the vein. And on the left, you see a lot of collateralization. On the right, you see less so. Now, the downside of this, right, it's actually a pretty good study, but the downside is if you just shoot one view, you might actually miss this, right? So you need multiple views evaluating for it because you can kind of get that pancake squashing effect of the venous compression. But you can find stenosis here, and they actually say if you have greater than 50% stenosis, it may be considered, sufficient grounds to provide therapy for symptomatic relief. So it's certainly a test that you may run into. The other and the last imaging modality that we're going to talk about here is something that's interesting for us, and it's certainly not because we're going to be doing this here in the emergency department, but intravascular ultrasound, right? This is something that can happen, though not a point of care study, right? And this is basically and oftentimes done in conjunction with the contrast venography, and you can use this to dynamically assess kind of the stenosis and even your therapeutics here, but you can basically thread an ultrasound catheter inside that vessel, and you can look at that compression in the area of the compression in the cross-sectional area of the area that's compressed, right? So on the left, we see a normal vessel, right? In the center, right? That black hole in the center is going to be representing the catheter. And so you see that, it's not quite anechoic, but that hypoechoic circle around it, and it's kind of marked by the green ring. That's a normal, vein. You can see the artery next to it marked by the blue arrow on the right. And then if you go onto the right-hand image, you see that compression causing a decreased cross-sectional area of that left iliac vein. with this catheter. And so it's a way of being able to detect, the stenosis, the location of the stenosis, and the cross-sectional area of that vein. You also use it to kind of assess some thrombi and things to that effect. So that's another thing that might be used to work this up. But the question that we need to know is, what do we do about this, right? So assuming we make the diagnosis, or at least presume the diagnosis in the emergency department, how do we manage these patients with May-Thurner syndrome, right? And I think we can break it down into three broad categories, right? We can describe, some cross-section between their symptoms, like symptomatic or asymptomatic, right? And then thrombotic or non-thrombotic, right? And so I put the green as the non-thrombotic side, the red is the thrombotic side. And I suppose you can make a category for asymptomatic thrombotic, but it's really not talked about in the articles that I, brought up, because it's just a super duper small group of people that have thrombi but don't have symptoms and didn't know about it, right? If you got thrombi, you probably know about it. And so you probably could just lump all those into the symptomatic thrombi group in terms of how to manage it, right? So these three main groups, asymptomatic, non-thrombotic is the easiest. Then, okay, what happens if you have symptoms of basically venous congestion? Those are the symptoms we're looking for. So claudication, venous congestion, things like that. And then what happens if you have symptoms and a clot, right? So in the asymptomatic non-thrombotic, there's not much to do. It's conservative management, maybe some compression stockings to kind of help, move the venous flow along and not, get it stuck in the legs, right? But really not a lot of active management that we're going to do. And these are probably not the patients that we're going to see because they're asymptomatic and probably just not showing up, right? They didn't know that they had it. And so they didn't know to ask us about it, right? What we may see, though, is people come in symptomatic but don't have a thrombus, right? And these are going to be a harder cohort to identify in the ED, especially if it's a de novo diagnosis, because, you don't have a thrombi, right? I'm not really thinking to go up and CT their pelvis to look for this compression. So this may be kind of a cohort of people that we kind of accidentally back ourselves into if we see this as an incidental on a CT scan. And really the thought here is if you have significant symptoms from this, right, you would benefit from some stenting to keep that vein open, whether it be stenting of the iliac vein or kind of extending that stent up into the IVC, and then putting you on some form of antiplatelet therapy just to allow that stent to kind of take in and not thrombose, right? And there's actually a scoring system. If you look in Up to Date at the end of it, there's a scoring system that you can use to say patients below this score are considered to be minimally symptomatic or asymptomatic, that you can kind of throw them in the conservative camp, versus if you're above a certain threshold, they're in the symptomatic camp, right? And they can benefit from this therapy. But what we really want to know about is what are we doing for the patients who we're scanning in the department, right? Who have a clot. We identified it. We maybe thought, oh, could this be May-Thurner syndrome, and got lucky on our CT scan and found it. Now what do we do, right? And so this is really the question of, that is going to be helpful for us in the ED or in the unit, right? And that's going to start with anticoagulation, right? We're going to put them on, heparin, or, probably heparin would be the easiest one just because you can take it off, if you need to have it off, or some other form of anticoagulation that you can just start them on, right? And then really think towards the idea of, do we need to get some catheter-directed thrombolysis, right? If you look in the up-to-date section on May-Thurner syndrome, they really lean heavily towards this whole idea of catheter-directed thrombolysis. And if you're not a candidate for a medically induced thrombolysis, whether that be with TPA or some other agent, then they were talking about other mechanical forms of thrombolysis or thrombectomy, right? And then that is generally followed with stenting, right? You don't really fix the problem by just getting rid of the clot. You still have that stenosis from the compression, the extrinsic compression of the vessel. And so you got to stent past that thing and open that thing up so you can keep your venous flow or venous blood flowing and prevent further clotting down the road. And then again, this is followed up with antiplatelet therapy for kind of to help that stent set in, right? So that's really your mainstay of management for these patients. But when it comes right down to it, this is a point of care ultrasound forum, right? And so this is great to know, but I've mentioned a lot of things that have to do with people other than ED or critical care docs, right? We're basically kind of at this point supervising the management, but not necessarily doing or identifying things, or really kind of helping us as we go to the bedside tomorrow saying, hey, here's a rare condition that you might want to know about. to fill your head with random factoids. And as an attending, this is really, really nice because it gives me kind of nice fertile ground to start asking questions of my residents and start pimping. But really, does it benefit me other than just memorizing another phone number from the phone book, right? And so what I want to do is kind of give us 3 implications of this condition that we may need to take to the bedside. So it's not just some random knowledge divorced from reality here, right? So implication number 1 is consider May-Thurner Syndrome with recurrence of DVTs, right? And as I said earlier, there's a huge push right now to start sending these patients home, especially as hospitals are full and staffing is low. You know, we are struggling to find resources to be able to manage patients in-house, right? And really asking ourselves the kind of the existential question is there something about the 4 walls of the hospital that makes people better faster? Or could we do the same thing but at home, with close management, right? And so while that's a very important discussion to have, it kind of pushes people to the outpatient world, and maybe we should not necessarily be so quick to push all the patients that we have, right? So should we start this patient on the DOAC and discharge them, or do we need to know about this so that we can think through what needs to be done potentially in-house, because a lot of the management of this stuff at least starts in-house. I can't give you TPA and put a stent in your home, right? So consider May-Thurner Syndrome with recurrent DVTs. And this is where your history really, really matters. As you're scanning the patients, do you have a previous DVT or is this the first one you've ever had, right? So having one DVT certainly does put you at risk for DVTs down the road, right? But if you notice the patients here with their second or third or fourth DVT, particularly in the same limb, and especially if you are a high-risk patient, remember the young female around the time of pregnancy, things like that, really you should start by asking yourself, could this be May-Thurner Syndrome? And should I bring this patient in to work them up? Or maybe just get my CT scan in the ED and bring them in if it's positive, right? So really start thinking through this rather than just saying, oh, it must have just been anticoagulation failure and you're a silly patient who doesn't take your medicines. Could this be something that's a little bit more significant, as we're seeing these patients back for recurrent DVTs, right? Second, be wary of proximal DVTs, right? And so one thing that takes our scans from kind of a mediocre level, like, okay, we can do scans and we're pretty good at doing scans, but really takes it to the next level of giving ourselves more information is, where is the DVT? Not just is it there, and can we see the whole thing, right? Can we see the leading edge of this thing, right? And so we talk about this in the context of, or a similar context would be like pneumothorax. It's one thing just to throw the probe on and say there's no lung sliding in this lung. They have a pneumothorax. You're probably not wrong, but not all pneumothoraces are treated the same, right? You put a chest tube in some, you don't put a chest tube in others. And so taking it to the next step is basically saying, okay, yes, I got a pneumothorax, but let me scan above and below and to the side and see how big this thing is, right? And this is kind of the same idea with DVTs, right? Put the probe on, no compression in, let's say, the mid-femoral vein. Great, you got a DVT. So we know kind of what the initial therapy is going to be. It's going to be anticoagulation. But you know what? Don't stop there, right? Take it to the next step. Scan up, scan down, find out how far this thing goes. Is it mostly distal? Like, does it come from the popliteal and come up and stop in the mid-fem? Or is it mid-fem and then goes all the way up into the common fem and up into the pelvis where you can't even see it, right? Because those are two very different beasts. One is very distal, one is really proximal. And while I'm starting to get into my own, a little bit of my own opinion here, I think it makes sense to say if something's super duper proximal, especially if you can't see the leading edge of the thing, you should have a really higher suspicion, of this DVT, because number one, it's in a big vessel, right? You have a bigger thrombus that's going to have a more likely, or going to have a bigger impact, if the thing embolizes. But could it be coming from a source that's proximal, right? Is where I'm trying to get at, versus something where you have, I was hit in the leg with a ball the other day, and now I've got a popliteal vein DVT, and that's it, right? Those are two very different things, and I would be less inclined to say that the latter one is coming from May-Thurner Syndrome, though I'm certain you could probably find a case report where it does, compared to the former one. And so where is this thing? Is it proximal, distal? How big is this thing? And can you find the leading edge, right? Can you scan, like on this picture, you can see kind of that leading edge in the left-hand side of the screen of this thrombus, right? And so continue scanning and consider May-Thurners if you have, large thrombi, especially if they're proximal, right? And the last implication for us at the bedside is if the bedside ultrasound, if point-of-care ultrasound doesn't give you your answer, keep looking, right? Especially if you consider this. Now, it doesn't mean that you say, I have an 85-year-old gentleman, who is, plays tennis every day and is, I don't know, making up a scenario here, with a right-sided, cellulitis, I got to think about May-Thurner Syndrome. Like, it doesn't fit, right? But if you have someone who's got, a concerning story, right, and you get your bedside ultrasound and you don't see anything, like in this example here, we have completely anechoic, completely compressible vessels all the way down the leg, maybe you're not done, right? Maybe we've missed something that's further up in the pelvis, especially if the story fits, where you have unilateral leg swelling and pain that doesn't really have a great understanding. Remember, like, we kind of get hooked onto this, the DVT scan's negative, it must be gone. But really, we've only scanned from the common femoral vein all the way down through the popliteal trifurcation. We haven't looked above and we haven't looked below that. And so if you look at this picture, remember, right, there's a lot of vasculature that happens from the inguinal ligament up to the, where the two iliac veins, collide essentially to form the IVC, right? And we're not really seeing a really good view of these vessels with our duplex ultrasound when we examine the legs, because like we mentioned earlier, there's a lot of overlying bowel gas and there's deeper structures. It's a lot harder place to evaluate, but it doesn't mean that thrombi can't happen here, right? And so if you have nothing distally, right, you got to at least consider that could there be something here. And so how do we consider that? And we talked a little bit about it last week. So basically, if we were to assess the ultrasound kind of at the level of that arrow, right, where if we put our probe there, right, we're going to get some degree of flow through that vessel, right? And as you take a deep breath, right, as we breathe in and then breathe out, we change the intrathoracic pressure in our chest, right? We breathe in, we get a negative pressure, right? We breathe out, we get a positive pressure, right? And this is we talked about this a lot in the context of, when we intubate someone, we convert them from negative to positive, intrathoracic pressure to all positive, right? Unless there's some really quirky breathing over the vent, and we can talk, random esoteric things. But we normally have this back and forth negative to positive intrathoracic pressure, and that's transmitted down the vessels, right? Think about it. If you're standing straight up, right, standing erect, and you got blood in your legs, right? It's got to somehow overcome gravity to get back up into your chest. And so we remember you have the muscular pump. So as you walk around, muscles squeeze and kind of squeeze that blood up. Great. But you still have a lot of gravity affecting blood in the IVC and things like that. And so this respiratory pump causing that negative pressure really kind of creates a pressure gradient. That blood flows down that pressure gradient from the IVC into the chest, despite gravity pulling it from the chest down towards its legs. And so we can actually see this when we scan patients, right? And so this image here, we can see we put pulse wave Doppler in this blood vessel, and we had the patient breathe. And this is just normal breathing. This isn't like take a deep breath, like a super high negative intrathoracic pressure. This is just normal breathing. You can see some undulation in terms of that, the venous waveform of the blood flowing through that vein, right? And so if you have zero obstruction, right, you're going to have a transmission of that venous pressure changes from the IVC down to where you're evaluating it in the probe, right? Compare that with someone where you put in an obstruction, right? So if you have an obstruction to that flow, like something, where this X is at, you're going to have a blunting, at least a blunt. You're probably going to have at least a blunting of that venous flow, if not just a complete, lack of respiratory phasic changes, right? And so this is something that's really helpful if you, as you're scanning your patients, put your probe kind of in the proximal vein, right? Put your pulse wave Doppler in there and have them take a deep breath and see what happens, right? And even compare that to the other side and see if it's the same from one side to the other, right? With the theory behind it being, if you have an obstruction to flow, a unilateral, obstruction to flow, you can see a blunting of that venous waveform, either compared to the other side or just a blunting altogether, right, as it relies on collateralization to get things back. The caveat to this is it's great, but it's not perfect, right? So just like urine jets don't prove the lack of obstruction or the presence thereof, right? This doesn't prove the lack of an obstruction or the presence. It just suggests it when you see this phenomenon happening. What it also does is it tells you that something's obstructing flow, but it doesn't tell you what that obstruction's from, right? So is it a thrombus that's intravascular? is it some compression that's extravascular, right? So something to look for that can help kind of tune us into this thought. And if you see this, great, right? Then you can kind of feel very justified in getting further imaging, getting your CT scanned to assess and see what that lack of flow is coming from, whether it be intrinsic or extrinsic. But if you don't see this, right, you still need to kind of keep this in the back of your mind, right? It still should prompt kind of some further thought. So those are the three things that I think are really helpful to kind of consider. Always be wary of May-Thurner syndrome with recurrent DVTs, right? Be wary of proximal DVTs, like look and see where these things are at. And if point of care ultrasound doesn't give you your answer, keep on looking. It doesn't necessarily mean the patient doesn't have it. Just keep looking if you have significant enough concern based on your clinical presentation. So I hope that's helpful. We certainly didn't go our complete time today, but I thought this was a unique enough case, and it's come up a couple times in the literature and things like that, where I think it's an important diagnosis for us to understand, because it really can have some significant implications when we see this and scan this at the bedside if the patient has May-Thurner syndrome. So with that being said, does anybody have any questions about this condition or things that they want to add in? Z, I know you're here, Sandy, you're here, Diane. Anything you guys want to add in about May-Thurner syndrome or DVTs in general?